I'm going to hand over to Zamo Mbele, who's a psychologist also on our team. He is a board member of SADC, and as you know, they do a lot of telephone therapy. And I asked him to just give us some brief guidelines on telephone therapy, which will be followed by some brief guidelines on virtual therapy. There were some questions in the forms which I sent out before the training, so we just wanted to cover this area. I'm sure a lot of you know this, but we'd like to just cover it just a bit. Thanks, Zamo.
Thank you, Antoinette, and thank you everybody for joining. As Antoinette said, I'll kind of just be brief because a lot of this might be intuitive to most people on this call, and you may know it in very many ways. It was quite important, though, for us to have this section covered because of the fact that a lot of people will be making contact telephonically. So what I've done is I've elaborated quite a bit with a few slides. I'll try to speak around them, and then you can have them as a resource to go through them. The first thing also to say is that myself and Alicia's approach is adjunct to that of Tina's. So Tina's discussed quite a lot of the content of what is to be done in the intervention, and then myself and Alicia were thinking a bit about the frame of it. And telephonically, there is, I guess, a pull or a distinction to be made here between telephonic counseling and therapy. And to reference Tina, a lot of the work that we will be doing and or asking you to do will be short-term, at the best of times, once-off, static, capsuled interventions. And it's important to hold that in mind going into the telephonic counseling or the telephonic check-in, in fact, is what we usually do at Tara, to know that there has to be a beginning, middle, and end to it. I think on the next slide, one of the things that I wanted to look at is if we're doing this for the purposes just of making contact, we know that people usually make contact telephonically as an adjunct or a support to a therapy. And this is oftentimes either at the beginning, the middle, or the end. The beginning to initiate your contact or to initiate some sort of therapy. In the middle is oftentimes if the therapist cannot be reached between sessions and or if there's a crisis, and at the end if it's for the purposes of conclusion, if there's been a disruption. And we recommend, as do the guidelines, that you actually oftentimes keep it to that. There are advantages and disadvantages that we might all be able to consider and think about. Perhaps just to highlight one is that it might be quite important to be conscious and conscientious of the privacy or where the person finds themselves when they're making these telephonic calls, and to help them think about it or to guide them in thinking about that as well. Usually the frame is set up for you in your own consulting rooms. In this regard, you may absolutely have to take charge and try set it up with the client that you're seeing as well. I want to move on a bit to then the kind of real important appropriateness assessments that you'll have to make. The first one is your intervention formulation. As I said a little bit earlier, to know and remember that it really may be once off. It may be that you only speak to this person, and the importance of knowing that formulation ahead of time will guide you in being able to assess how much you can go into, and very certainly most of the times, in fact, be very limited in what it is that you are pressing on and touching on. Patient profile assessment is incredibly important. Without getting into it too much, the three kind of contraindications or where you must exercise a great deal of caution are psychotic patients, patients with extreme dysregulation, especially if they're by themselves in a situation, and homicidal patients are three categories which are known to be quite difficult. And then I thought it was quite helpful also for you to make an assessment of yourself, not only around when and where you're taking your phone call, though what's your availability to continue with this intervention further. It's important. Third last thing that I want to look at a little bit is the importance of setting the frame, not just as we've discussed in terms of environmental, though also in knowing the limitations of a telephonic counseling or a telephonic check-in, that it is not and will not be a therapy most of the time, and to speak that out so as not to drop the person on the other side as well. And again, to allow you to set up your interventions appropriately in the 30 or 40 or 50 or an hour or 60 minutes that you will have. I'm going to skip the next few slides. As I said, they're there for you to have a look at how, establishing rapport. Tina, I think, spoke to that, building a clear picture of the context that's available to you, and as well as kind of the simple curiosity that is necessary on these calls. The next slide, though, is quite important in the ending and how to contain your telephonic counseling. And as I think has been said already, the importance or the capacity to recruit families or friends that the person may be calling to try and assist you, especially if it's a crisis call, which is what we see a lot of at SADC, as well as then additional resources, including, for example, the SADC call line, casualties, and other healthcare professionals that the client or the patient may in fact be seeing. So not just a reminder for yourself to know, and to recruit that in the conversation that you're having, so that by the end of each phone call, there is an action plan that you can refer to as well. Last thing on that is maybe just an important thing to think about are the practicalities of when somebody calls you, to the extent that the caller ID is hidden. Try and get an emergency contact quite ahead of time. You yourself would need to familiarize yourself with emergency contacts to somewhat regionally. I mean, you have fortunately the ability to use Googles for those things. Those were some helpful tips on how to end your phone call too. Thank you. And I'll hand over to my colleague, Alicia Vaccari, who is in a private practice currently, though has almost 2 decades of experience in the public sector as well.
Thank you, Zamo. Thank you for everyone's presence and joining us for today's training. So I want to build my presentation with Zamo and Tina's one, because to me, virtual therapy is about what Tina spoke about, the techniques that you're going to be using with your clients, but also I found very important to think about what Zamo said about really having clear in your mind what are you thinking, what is your agenda with your clients. If it's going to be a once-off consultation, is it going to be short-term or long-term? So those are very important things, and online therapy maybe is a little bit different because it has sort of like a different frame as we speak, like internet connections for you or for the client, the platform you use, which one is legal, which one is recommended, which one is advisable, and on the device that you use. I found that it's important to think about patients or clients that sort of connect with the phone, clients that connect with the laptop, and also the rooms or the sort of all the environment that they use to connect with for the session. And it's important to maybe send an email and make very clear to them that it's important to have a space where they shouldn't be interrupted, the connection should be good, and so on. And it feels to me, when I started to do online therapy, that it's setting up almost another office besides the office that I used to see my clients face to face. In terms of the medical indemnity and consent form, my colleague Judith Ancer will speak about those things, but I think are extremely important in those sort of different platforms that we are using these days to do therapy. Many of you may be doing already online therapy, but it's important for the training and for the intervention that we're doing in the COVID-19 team to think about the more short-term or the crisis intervention approach. And online therapy has many of the challenges that Zamo already spoke about in terms of telephonic counseling. Something that also I would like to mention, and maybe in the question section you can ask more about it, but something that I would like to mention is, it feels to me that many of us, we are so used to, and we were trained in doing face-to-face therapy and having the client in front of us and reading body language, the tone, the sort of avoiding eye contact and so on. So we have been trained and we are comfortable with that type of intervention. But these days, with this pandemic, we are forced to use other resources. So we are out of our comfort zone. And I think what we need to really think about is almost trying to, in a way, give up or transform or sort of transpolate what we were trained and our skills into this new setting, because right now is the only way to do it. But it can be also sometimes very useful for some clients that I found, and I'm not sure what your experiences are, that clients are much more comfortable with having therapy online than seeing someone face to face. So to me, it's about changing the focus and somehow having to learn a new way of relating. But in terms of pros and cons, I don't find it extremely disadvantaged, if that makes sense. So those are my thoughts and my points in virtual therapy, and maybe at the end we can hear more questions from you. And now to my colleague Judith Ancer, and she will speak about ethical issues. And I'm not sure if Judith needs a introduction, but she's a very well-known psychologist in private practice and good friend. Judith, to you.
Well, thank you all. I'm going to talk very briefly about the ethical issues that are at play, and really you can go, whether it's to the HPCSA website or to the SACSIS, that's for the social workers website, to look at your guidelines. But essentially the major things in terms of our requirements as an kind of a loose body of all volunteers is that we ask that you get consent from each client or patient that is referred to you. And what we've decided is that the client doesn't belong to our platform or our organization. The client or caller who is assigned to you, and Antoinette's team are doing that and trying to spread the referrals as widely as possible, that client becomes your responsibility. They're part of your practice, even though you're not being paid to see them. So we don't have the relationship with you as a service provider like an EWP might have. But that, having said that, we do ask and we do require that all our volunteers are formally registered with either the HPCSA or SACSIPA. I can't say SACSIPA, it drives me mad. And we do ask that you get consent. So we know that the criteria for consent is anybody over 18 and anybody over 12 with capacity. I don't know how many people there are under 18 who are healthcare workers, and we haven't made formal decisions about the families of healthcare workers at this point. But, the important thing is if someone has capacity, unless they're impaired, they have capacity to consent. In an ideal world, you would send them your consent form that acknowledges that this might be a telephonic or online session, and that they would, in an ideal world, have time and the ability to scan it, to sign it. But we understand that many people don't have that ability or time or capacity to do that. So we ask then that at the least you do is get either an email response that says, I agree to the process. It can be a WhatsApp or text response that you keep record of. And if you can't get any kind of text or SMS response or WhatsApp response, even oral consent is valid, according to the HPCSA, for example, as long as you record that. So it's really important that you also clarify the informed part of the consent is that you clarify that you're not paying for up to 4 sessions, that you will not be paid. We have agreed informally that if any of the clients who call in would like to continue a process with you after the 4 sessions, they are welcome to contract with you privately in whatever form you would like to do. If that's pro bono or through their medical aid or however you negotiate that, what we ask is for just information that you've made contact with the client, that you've seen them, and that you've ended with them. So record keeping from our side is just about process and data, not about the content of the session, except when we ask for the broadest kind of sense of themes so that we can refine and understand our what is happening.